From Microbe TV, this is TWiP, This Week in Parasitism, episode 233, recorded on April 9th, 2024. I'm Vincent Racaniello. You're listening to the podcast all about parasitism. Joining me today from Fort Lee, New Jersey, Dixon Despommier.
Hello, Vincent and everybody else. Gorgeous day out there today. It feels like mid-spring rather than early spring. The temperature actually in Fort Lee, New Jersey went up to 80 degrees. But
Wow.
let me just say that if today is a wonderful day, then yesterday was an even more wonderful day because we won't have time for this, but my wife and I went up near Montreal in the morning and witnessed a full total eclipse of the sun. And we had a fantastic time. We didn't get home till 1 o'clock in the morning, and we're still talking about it.
Bad boy.
Oh, you're kidding. The
Let me
traffic was
introduce the
incredible.
others. Dixon, let's introduce the others, and then we can all talk about the eclipse.
You bet.
Also joining us from New York, Daniel Griffin.
Hello, everyone.
And from Glasgow, Scotland, Christina Naula.
Hello, everybody. It's been blowing a hula here and my hair is all messed up. But other than that, life is good.
Life is good.
What was that thing? It is blowing something?
Blowing a hula.
Okay.
It's been very windy.
Okay, I'm not familiar with that. So, Dixon, you were telling us about a full total eclipse. So you use both words full and total. What's the...
Well, I think it's redundant. If you say it's a total and it's a full, it's the same thing.
Oh, okay. I thought it was like the full Monty total eclipse. And
No, that's totally different. That's a totally different moon.
I know I wasn't invited.
Oh, Daniel, that's a totally different moon.
That's funny. Daniel, did you see the eclipse at all?
You know, I was working in the hospital, and then all of a sudden, nobody was there except for me and the patients.
Right.
And so, no, I really had a lot, very busy yesterday. So I was, can you believe that? I was not able to view the eclipse. But
so I guess, Christina, you didn't have it in your country, right?
No. It also would have been too cloudy to witness anything. Yeah. I did see a solar eclipse, though, a complete one, I don't know, in the early 2000s. Really, really amazing. And then a partial eclipse maybe around 2010. So that was also quite a good experience.
There's still time for everybody here to get tickets to the next total eclipse, which is approachable 3 years from now in Luxor, Egypt.
Why do you need tickets?
Wow.
You need an airplane fare, you see. You don't need tickets to get into the eclipse. But you do need to get to Luxor somehow.
Yesterday, I left for my class at 3:15, and I went out on 7th Avenue. People were lined up looking up because there's a low building here. The Fashion Institute of Technology actually is very low. You could see the sun above it. I couldn't see anything because it's too bright. So I went to the subway. I went to campus to teach, and all the students are out looking up. So I take my camera, and I'm going to take a picture, and then there's this guy cleaning the sidewalk. He said, no, you ruined your camera. And he gave me a pair of glasses. He said, put this in front of your camera. Wow. But I wore them, and I could see it up there. It was so cool.
Amazing.
And then I took a picture. But it's it gives you this community event, right? Everybody's looking at the same thing. And you feel, for once, this is humanity. We're all united. We're looking at an eclipse.
Well, not really, though, because only 36 million of us got to look at it.
Yeah, I know.
But nonetheless, it's an awe-inspiring event.
I mean, 36 million Americans can't agree on anything, but they did like the solar eclipse.
But I'm glad there's another one coming up, because I was under the false impression, I now realize, that it was going to be 45 years before the next one. So when people asked why I hadn't gone, I was like, it's okay. In 45 years, I'll be retired and I can spend the whole day.
You're such an optimist.
I think for 45 years,
I'll be retired by then, or
sorry.
Knowing you're never going to retire, and nor should you. You should continue to do good. You're a wonderful physician. Don't give it up, please.
I was going to say that the 45 years, Daniel, I think that refers to a solar eclipse in the US, maybe.
Oh, maybe that. Yeah, then I won't have to travel. I just would
There
walk
is another
outside.
Yeah, it's 20 years, actually 20 years within the United States. I don't know where it's going to be, but
So you may have noticed, intrepid listeners will notice that I said you're listening to the podcast about parasitism. I have never said that, but of course, the name of this podcast is This Week in Parasitism.
right,
And the TWiP was the second podcast that I started
right.
after TWiV. It was a couple of years of TWiV success, and I said to Dixon, we should really do a parasite podcast. That was your thing. And he said, yes. And he came up with the name parasitism. We wanted to do This Week in Something. So Dixon, why parasitism and not parasitology?
Well, ology is the study of parasites, and this thing goes way beyond that. And it studies, it covers the waterfront of any organism that takes advantage of another organism by crawling inside of it and commandeering a portion of its normal biology for its own purposes.
So it could be a virus too, right, Dixon?
Oh yeah, no, absolutely. You betcha.
Yes.
Except that, you can't really classify viruses as organisms, but that's all right. It's not a philosophical discussion.
I can do anything I want.
You could, but it would be wrong.
Wrong by who? Wrong by who? Who's the arbiter of?
Yeah,
It depends on who hears you.
Listen to this. I mean, I say that a virus is an organism with two phases. There's the virus particle, which is not living, and then there's the infected cell, which is living. So the infected cell is obviously an organism.
That's true.
That's why I say it's an organism.
I would agree with
that. But I agree, the particle is not, but it's not on its own. It doesn't exist on its own, because if only a virus particle existed, it would never reproduce, right?
Nothing in nature exists alone.
We just sit there. That's right.
That's right. Nothing in nature exists alone. Yeah. Or as who was the British worm guy? Sidney Brenner. He said,
right.
Anything made by evolution is bound to be a bit of a mess. That's a good one. All right. If you like our programs and would love to support us, we would welcome your financial support. Go to microbe.tv/contribute. All right, Daniel. This week is Solving a Case Week.
Yes.
What are we solving, Daniel?
Yeah. So, I think when we say This Week in Parasitism, we've tried to let our listeners know that for most of the time, we will be focusing on the eukaryotic non-fungal parasites, right? That's got to qualify that, right? And so we have a mystery case that we presented several weeks ago. It looks like we've got a lot of guesses. And what was the mystery case? So the story is a physician, otherwise healthy, no past medical history, currently doing their fellowship training, and it's in the field of hematology oncology, develops diarrhea. Now, the diarrhea is significant enough that they're beginning to feel weak, lightheaded, end up actually going to the local ER. The physician lives in New York City, works most of the time, but did just get a chance to take a week-long vacation in Florida with their long-term partner, where they got a chance to swim in the pool, get some sun. Now, they returned feeling well, but then noted the onset of the diarrhea. The diarrhea was watery with some abdominal cramping, no noted blood or actual fever. The stool did not have a strong smell. No floating stools were reported. The physician was given IV fluids, returned home feeling better, but now gets a call that there is a parasite on the stool testing and is recommended to take a medicine they have never heard of 3 times per day for 3 days. And I will add a little follow-up. This is followed by full recovery.
Well, we had quite a few guesses this time. Must have been easy, huh? The easy ones get a lot of guesses. All right, Dixon, can you take that first one?
Justin writes, "Hello all. After a number of wrong answers in a row, I hope to give a better guess this time. In the case of a physician returning from a vacation in South Florida with watery diarrhea, my initial thoughts turned to giardiasis, cryptosporidiosis, and cyclosporiasis. Cyclosporiasis. Giardia is out due to the lack of foul-smelling fatty feces. Crypto and cyclo both seem like strong potentials, with crypto being more common. So I will guess crypto as my final guess this time. As always, thank you for a lovely podcast. Yours, Justin.
Christina.
Annette writes, "Hello everybody. Greetings from an overcast, windy Braunschweig at just 13C. I think the physician has got cryptosporidiosis, as the diarrhea is not foul-smelling and is being treated 3 times daily, probably with nitrous oxide. Looking forward to listen to all those well-written letters. Thank you for all your podcasts. Grüße, Annette."
What does Grüße mean, Christina?
Greetings.
Greetings?
Yeah.
Ah. Okay. Daniel.
Ayal writes, "Dear Vincent, Dixon, Daniel, and Christina, greetings from Sydney, Australia, where autumn has arrived. And thankfully, the summer was not as harsh and forgiving as our firefighters have feared. Unfortunately, I didn't pick up too many clues from the case description besides most likely picking up the parasite in a pool in Florida. 2 parasites came to my mind when thinking of abdominal parasites in pool water. The first is Giardia, and the second is Cryptosporidium. For some reason, Chrome keeps trying to correct to cryptocurrency. In terms of differentiation between the two, I can't make a decision. Both have similar symptoms, similar incubation periods of 7 days on average. Both may come up in a stool exam. Looking through the CDC website, it appears that Giardia treatment options are fairly established, where there is only one treatment option available for crypto, which is recommended to be taken for 3 days. Also, I don't think we had a Cryptosporidium diagnosis in the last few years. So based on some very tenuous reasoning, my guess is crypto. Hope you all had a great Easter and wishing you a lovely spring season."
I think that's great. Cryptocurrency. I love that. Hawken writes, "Greetings from sunny Athens again. Thanks for another fun case. Having also suffered from this fun little bug in Florida, and then again while working with calves, I pity this individual. My guess would be a Cryptosporidium species acquired from the local pool. Differentials I considered as well included Giardia or Entamoeba, but ultimately the fact that a pool kept being mentioned, it seemed most likely to be crypto. Given how resistant this protist can be to chlorination, hopefully the pool is cleaned adequately and there are some more signs posted. Please don't swim with diarrhea." Oh my God, that's horrible. Thanks again, Hawken. Dixon, we're back to you.
We are. Anthony writes, "The mention of a swimming pool likely points to Cryptosporidium, as it can resist most common disinfectants." Anthony. Very succinct.
Take the next one. You can take the next one, Dixon.
Okay. Anne writes, "Dear TWiP team, my answer for the case of a physician with watery diarrhea is infection with Cryptosporidium parvum, which may be treated with nitazoxanol, TID. It is also the most common of the likely infections. I considered Cyclospora cayetanensis, but figured most physicians would have heard of metronidazole. However, I may be biased since I'm a veterinarian, and metronidazole is a common drug in my field. I've been listening to TWiP for years, even before Dr. Griffin joined, but I am usually catching up on episodes long after the entry period for guesses. My daughter is now a second-year medical student, and I would very much like to win a hard copy of the book for her, so I hope to be more diligent in responding. Warm regards and many thanks for all you do for science and public education across the TWi multiverse."
I think it's pronounced twee, Dixon.
Well, some say TWi, some say twee.
Christina.
I don't know TWi, but they do.
Marie writes, "Hi there. Hope I'm not too late in submitting this. My name is Marie. I'm currently a college student and aspiring parasitologist. I found your podcast recently and I fell in love. I'm sure I'm going to embarrass myself over the internet, but my guess for this case would be cryptosporidiosis. Given the incubation period, as well as the voluminous, watery diarrhea, Cryptosporidium species would make the most sense. Giardia would be another cause, but if I'm remembering correctly, giardiasis causes foul-smelling, floating, greasy diarrhea, which wouldn't exactly align with this case. The fact that the patient spent most of their time in the swimming pool, again, points to cryptosporidiosis due to several past outbreaks originating from public swimming pools. I also thought about the cuisine that's popular in Florida and which seafoods could possibly cause these symptoms. The only thing I could think of in that regard is vibriosis, which, as we know, isn't a parasite, but is one of my favorite bacteria. So yes, my final guess would be Cryptosporidium, though I admit I am stumped on what the mentioned risky behavior could have alluded to. Thank you all so much for what you do, and I hope you are having a lovely day or night wherever you may be located. Sincerely, Marie.
I think that's funny. Day or night or wherever you, what was it, the bottom of the ocean or something?
Or maybe on the moon.
All right. Daniel, you're next.
Felix writes, Dear hosts, greetings from sunny Germany. Seems like there was not only water in that hotel pool, even though mostly known for the prolonged infections in immunocompromised hosts, cryptosporidiosis fits the case description perfectly, since their oocysts are doing fine in chlorine-treated pool water. According to Wikipedia, a median dose of 132 oocysts is needed for infection of a healthy individual, so he might have taken in a little too much of the SHITTY pool water. Treatment can be symptomatic since it's mostly self-limiting or with nitazoxanide. I found a regimen of 2 times 500 milligrams per day for 3 days, but maybe I'm off on my diagnosis. Until next time, Felix.
Wow. University of Oklahoma undergraduate parasitology course writes, Dear TWiP folks, it's a gorgeous, sunny spring morning here in Norman, Oklahoma, 62F, 17C. The wind is under 10 miles per hour. For Oklahoma, that's a still day, and the skies are clear. I might take a risk and plant out some of the tomatoes waiting in the greenhouse. It's a little early in the season, but I'm prepared to cover them if we get a frost warning. I'm writing on behalf of the University of Oklahoma undergraduate parasitology course, which I was drafted at the last minute to teach this semester with less than 2 weeks to prepare for a course I had never taught before. In a previous life, I was a caddisfly taxonomist, and I occasionally teach in the biology program here as an adjunct. Parasites, especially insect-vectored ones, have been my side fascination for a long time, so I was excited to have an excuse to immerse myself in the world of worms and protists. I've been having a great time, and I hope the students are enjoying the class and learning as much as I am. Almost all our students in biology are planning careers in healthcare, and I'm trying my best to make sure the 24 in my class will be prepared for parasites when they encounter them in their future work. 2 weeks ago, right after I gave the midterm, I stumbled across your podcast. I've been bringing episodes with absolute delight, nearly nonstop, and to the horror of my oldest son, who is more squeamish than you would expect from the child of 2 biologists to be. I'm only sorry I didn't start listening earlier and wasn't able to share it with students until after spring break. I immediately dug through the archive to find episodes we could use as homework exercises, and the students really seemed to enjoy that. Today we listened to the latest episode at the end of our tapeworm lab and worked together to solve the case of the doctor with diarrhea. I love that. The doctor with diarrhea. We started with the table of symptoms in the clinical appendix of PD7. The parasites listed with diarrhea as a symptom are giardiasis, cryptosporidiosis, amoebiasis, balantidiasis, cystoisosporiasis, cyclosporiasis. Oh my God, it keeps going on. Blastocystosis, dientamoebiasis, trichoriasis, strongyloidiasis, trichinellosis, intestinal capillariasis, anisakiasis, mesocestodiasis, schistosomiasis, and paragonimiasis. Lack of fever was noted, so we downgraded balantidiasis, trichinellosis, anisakiasis, schistosomiasis, and paragonimiasis as less likely. Thank God I don't have to say them all again. We eliminated giardiasis because the lack of a strong odor of floating stools was noted. No blood in the stool, so amoebiasis seems less likely. Of the remaining parasites, the only one, according to PD7, that has a treatment regimen of 3 times a day for 3 days is Cryptosporidium, treated with detoxinide. I suppose that it is a drug that might be unfamiliar to a newer physician. Cryptosporidium also came up in our Google search as the parasite most associated with swimming pool exposure. And the CDC tells us how difficult it is to remove from pools. The timing of symptom onset also seems consistent for Cryptosporidium, with the range being 2 to 10 days and the average 7 days, although we are not given the precise number of days between the patient's return from Florida and the appearance of diarrhea. The one piece of information we were not really able to address was the risky behavior noted by Dr. Griffin. If that was the source of infection, that might have been drinking pool water or drinking a questionable food or beverage. But if one of those was the risky behavior, that would also be consistent with Cryptosporidium. We look forward to hearing the revelation of the actual diagnosis. Thank you for providing parasite enthusiasts and the parasite curious with this fabulous source of education and entertainment. Aisha, who is a PhD in the students of biology 4653, Abby, Corinne, Hannah, Devin, Mariah, David, Lance, Daniela, Adam, Abigail, Corey, Lauren, Breyer, Keem, Alex, Kathleen, Christina, Peyton, Clara, Laura, Marcos, Tamara, Oliver, and Colin. No Daniels, no Vincents, no Dixons.
Go figure.
But there is a Christina there. That's cool. I think this is great. Thank you so much. All right, back to the top. Dixon.
Carol writes, "Good evening. I would like to submit a guess for the new case of the doctor who develops diarrhea after returning home from vacation. I believe that the parasite infecting them is Cryptosporidium parvum, and it was ingested during swim time in the pool. I hope I'm right. Looking forward to winning a book. Thanks for the great podcast. I really enjoy listening."
Christina.
Jay writes, "Dear TWiPsters, this case brings to mind the Karl Popper quotation cited in TWiP 1100. Our knowledge can only be finite, while our ignorance must necessarily be infinite. Our understanding of diarrhea and of the microbiome and the GI tract is quite finite. Our ignorance of it is infinite. Our understanding of the sex and love lives of others is also finite. Our ignorance of it is vast. This young HIV-negative physician developed watery, non-bloody diarrhea less than 10 days after returning from a week of rest and poolside relaxation with their partner in Florida. The dehydration and weakness from the diarrhea were severe, so the patient sought help in an ER. There, IV hydration was given and stool testing was done. The patient felt a bit better after the ER visit. A few days later, the patient received a call with results. Stool testing was positive for a parasite, and a 3-day course of a 3 times a day medication was recommended. This physician, who is receiving advanced training, had never heard of this medication. I suspect the parasite found in his stool studies was not the cause of his diarrhea, and the medication that was recommended was not an antiparasitic drug. I suspect the parasite was a commensal, a benign resident of the complex rainforest that is the GI tract, rather than a pathogen. My guess is it was either Blastocystis hominis or Endolimax nana. The medication may have been Saccharomyces boulardii. There are 4 clues that led to this conclusion. Clue 1. The diarrhea was not particularly malodorous. The stool did not float, and symptoms began less than 10 days after his return. Scratch stinky, greasy, floaty giardia off the list. There are also reasons to scratch Cryptosporidium, Entamoeba histolytica, and other parasites off the list. Clue 2. The diarrhea was watery, voluminous, and self-limited. It sounds like either enterotoxigenic E. coli or viral cause. I think ETEC, enterotoxic E. coli, is most likely. It usually resolves without antibiotics. Clue 3. A 3 times a day medication for 3 days. I suspect this was Saccharomyces boulardii to help recolonize and soothe the GI tract after the voluminous diarrhea power-washed the normal flora away. Numerous studies over recent years have shown the benefits and efficacy of this probiotic yeast. S. boulardii remains unknown to many medical providers, so it's understandable that this physician had not heard of it. Clue 4 points to the course of the exposure, a risky behavior. The source was likely exposure to the partner's GI flora, including E. coli, acquired through sexual activity. Oral anal contact, or rimming, is a common sexual practice. It may seem salacious to delve into these details, but our task as physicians, scientists, and healers is one, to understand, and two, to help others live in the healthiest way possible, the lives they want to live. We may find other sexual practices objectionable, or we may find those practices enticing, but our feelings about it are beside the point. Our role is to help, not to judge. Great case. Keep it flowing. Jay.
That's great. That last paragraph is perfect, right?
Mm.
Our role is to help, not to judge.
It's true.
I love it.
All right. How am I going to pronounce that? Tuomas?
Tuomas, I think.
Tuomas. Yeah. Tuomas writes, "Hello, everyone, and thank you for all you do. I will start from the most specific clue, which wouldn't be available if Daniel hadn't already solved the case. Medication 3 times a day for 3 days. This leads me toward Giardia lamblia. Could be acquired in the United States, check. Diarrhea, check. However, patient denies floating stools, and G. lamblia is the only parasite in the book that has a mention of floating stool. Next one is Cryptosporidium parvum or hominis. Symptoms fit, could be acquired in New York or in Florida. Daniel volunteered the patient's HIV status before Vincent asked about it. Non-promiscuous sexual history is highlighted. These are relevant because crypto is known to be deadly to patients with AIDS, but limited to watery diarrhea in healthy patients. Treatment is nitazoxanide 3 times a day for 3 to 14 days. This is consistent with prescription of TID for 3 days. Patient is a physician that has never heard of the drug prescribed. A patient who has never heard of nitazoxanide is plausible. Can't figure out if nitazoxanide is an antimicrobial or not. The book says there's limited evidence of benefit for the medication in treatment of crypto. If it were an antimicrobial and it had no expected impact on the patient's recovery, Daniel would not prescribe it. If it is not an antimicrobial and only helps end the diarrhea sooner, then Daniel could prescribe it for crypto. Finally, what would the patient do that Daniel would not? Wear a tie to work? Impossible to say. And unclear why that would be a risk for the physician rather than the physician's patient. My guess is the patient ate a salad. Best regards, Thomas.
I don't know. Eating a salad is not quite risky, is it?
Well, remember Hawaii.
Mm.
Oh, in Hawaii, yeah, the lungworms, right?
The rat lungworm, yep.
But Florida, less risky, I think.
Florida might be okay.
I mean, Florida's protected by its Surgeon General, right? He's very careful.
When my parents spent a lot of time in Florida, there was a housekeeper, and she was from a country where there weren't quite the same hygiene standards. And at one point, my mother realized that she was still washing all the fruits and vegetables, lettuce in a dilute bleach solution. So Esther was explained to Esther that, you could actually rinse them. The water here in America coming out of the tap was safe. So
I think I'm next, right? Yeah.
Mm-hmm.
it's all you.
Michelle and Alexander from the First Vienna Parasitology Passion Club write, "Dear friends of runny stools and running gags." This episode has a special meaning to us since Michelle has returned home to Vienna from the U.S., and this is the first time we are able to work on a case while sitting next to each other and enjoying a delicious tiki drink together. A tiki, not quite really for Vienna, is it? Went to a tiki bar in, where was I recently? Texas.
You're in Texas? Yeah.
In Austin. It was a very famous tiki bar. Oh my gosh, the food was so good. The drinks were amazing. Our patient is a physician living in New York City who recently returned from a vacation in Florida. After getting back, they started experiencing non-bloody watery diarrhea, weakness and abdominal cramps, no fever. We think there are a few probable diagnoses in this case. Cryptosporidium parvum or hominis or crypto is contracted through contact with contaminated water and food or through direct contact with infected persons. The parasite has an incubation period of 3 to 7 days and usually causes non-bloody watery diarrhea, nausea, and vomiting. Cyclosporia cayetanensis is a parasitic disease. Well, actually, it's a parasite that causes a disease. that can be found worldwide, and is clinically not too different from crypto. Cyclospora is usually difficult to detect via microscopy. Giardiasis is a common diarrheal infection, but generally presents with foul-smelling diarrhea and fatty stools, which are absent in our patient. Infection with Entamoeba histolytica is usually accompanied by bloody stools, which our patient does not have. Cystoisospora belli only causes serious infections in HIV-positive persons. Going on symptoms alone, it's difficult to make a diagnosis with certainty, but taking other pieces of information from the case description, we can infer a little more. The patient received a call somewhat soon after returning home, which implies that the diagnostic test used here has a short turnaround time. As the symptoms were not very specific for parasitic infection, I would not be certain that microscopy would be performed here. The application of syndromic point-of-care PCR testing is much more likely. The most commonly used product for this application is the BioFire GI panel, which detects only 4 parasites, 2 of which fit the symptoms, Cryptosporidium and Cyclospora. Seeing as Cyclospora is generally treated with 7 days of twice-daily TMP SMX, with which the patient would be very familiar, we believe that the diagnosis is cryptosporidiosis. This infection does not usually cause severe symptoms in immunocompetent hosts, but can be devastating and even deadly in patients living with uncontrolled HIV infection. In this case, the patient required medical attention for dehydration, which warrants an antimicrobial treatment as would prolong diarrheal symptoms. The treatment is natoxinide, 500 mg TID for 3 days. If the drug is unavailable, paromomycin may be used. Thank you for this great case. All the best, Michelle and Alexander from the First Vienna Parasitology Passion Club. All right, Dixon.
Yes, Frithoff writes, hello from Hanover, Germany. We currently get a small taste of summer with nice and sunny weather at 23C/73F here in northern Germany. I'm a 5th-year medical student, and since about 3 years ago, when I discovered TWiV and then soon later also TWiP, I am a passionate listener of your programs. Up until now, I have been too shy to write your solutions of the medical cases that you feature every month, but now I think I've solved the case. I have 2 different differential diagnoses regarding the case of a physician returning from vacation in Florida and developing diarrhea presented in TWiP 231. Both these parasitic diseases can be transmitted by contaminated water, maybe from a swimming pool. My preferred diagnosis would be cryptosporidiosis, which about 7 days post-infection leads to watery diarrhea and can be treated with nitazoxanol 3 times daily for 3 days. The second differential diagnosis would be giardiasis, which also leads to watery diarrhea less than 10 days post-infection and can be treated with metronidazole. Oh, I guess the physician should know this drug. Or just like cryptosporidiosis with nitazoxanide. Giardiasis usually leads to smelly stools, making this differential diagnosis less likely than cryptosporidiosis. Thank you for all your interesting podcasts and cases. Hopefully, I'm not too late with my solution. I am very much looking forward to the next episode when another TWiP is parasitic.
Very good. Now, for Christina, let me just say this last one, I queried ChatGPT, and I thought it would be informative for us to see what it said. So go ahead.
Okay, ChatGPT writes, based on the symptoms described, watery diarrhea, abdominal cramping, no blood or fever, no strong smell or floating stools, one possible diagnosis could be giardiasis, which is caused by the parasite Giardia lamblia. Giardiasis typically presents with symptoms such as watery diarrhea, abdominal cramps, bloating, gas, nausea, and sometimes vomiting. Fever is usually absent or mild. The stool may not have a particularly foul smell, and there may not be any visible blood. Additionally, stools may not float in all cases. Giardiasis is commonly transmitted through contaminated water or food, and it is one of the most common parasitic infections worldwide. Diagnosis is usually confirmed through stool sample analysis, where the parasite or its cysts can be identified under a microscope. Vincent typed in, what is the diagnosis for a parasite that causes watery diarrhea with some abdominal cramping, but no noted blood or actual fever. The stool did not have a strong smell and no floating stools were reported. When I added swimming pool, and that's Vincent talking, it decided it was Cryptosporidium.
Completely changed the whole it's very interesting. Swimming pool changed the whole diagnosis. But we're not even...
I think I'm going to continue going to see a doctor instead of asking ChatGPT.
Well, in fact, and every time you ask it, the last sentence is, you should go see a doctor.
All right. Okay. Well, that's reassuring.
Yeah. But I'm just curious because so many people are using it. And you can see the query makes a big difference, right?
Yeah.
You add swimming pool and it completely changes.
Yeah.
And we're not even sure that swimming pool is the thing here, right? So anyway, those were our guesses. ChatGPT does not get to be entered in a book.
Okay. No book for ChatGPT. So do we have, 3 more guesses? And what are people thinking?
Do you want me to go first?
You go first, Christina.
Yeah, so actually a lot of the thoughts that went through my head have already been kind of read out, but I'll just talk you through my thought process anyway. So I'm of course in a privileged position because unlike Daniel, who saw this patient, I don't have to consider any common bacterial causes of diarrhea in travelers or non-infectious causes because we are recording this week in parasitism. So I think that excluded quite a lot of pathogens already. So I was thinking of giardiasis, but I discounted that very quickly, even though it's the most probable cause of acute parasitic diarrhea. But we can exclude it because of the foul-smelling, greasy stools that often presents with, and also I think that was it. The foul-smelling, greasy stools. That's all I wanted to say. So. And then I also excluded amoebiasis caused by Entamoeba histolytica, which are often asymptomatic, but it presents often with dysentery, so bloody mucousy diarrhea. So the watery diarrhea that we see here is not likely caused by Entamoeba histolytica. Then I was thinking of Cyclospora cayetensis. I think that the symptoms probably do fit, and also the incubation period. And so this typically manifests as a watery diarrhea of varying severity. There have been outbreaks in the US, but these have been linked to the consumption of fresh produce, so maybe leafy pre-packed greens and salads. And I couldn't find an outbreak that was linked to swimming pools. Although the parasite is actually fairly resistant to chlorination as well. So that doesn't match with the exposure described. And then there was also the treatment, which is Bactrim. I think that's the common name or the trade name for that. And I think any doctor would really know that drug. And it would also be a 7-day course, I think. And then my main contender was really Cryptosporidium. Which kind of fits the symptoms. So the most common symptoms, if symptoms present in an immune competent patient, I think that would be watery diarrhea, can also have stomach cramps and pain and dehydration, which we see here. But most commonly, actually, people don't have symptoms at all. And I think in the US, so Cryptosporidium, is often, the outbreaks are often associated with swimming in chlorinated public swimming pools, so that fits. And then I think the only drug that is approved in the US, although I'm not sure, I'm sure Daniel will be able to tell me that, is nitazoxanide, which the doctor may be not familiar with. And we don't know what kind of doctor he is, so if he's a cardiologist, that might just not be on his list of drugs that you commonly use. And the treatment recommendation also seems to fit. So I think my diagnosis is Cryptosporidium.
Wow, so beating up on the cardiologist, just like Vincent.
Well, actually, I was thinking that as I was saying it, but I couldn't stop it. So I apologize to all cardiologists.
I hope they take our comments to heart, that's all.
Yeah, no, I'm just apologizing to all cardiologist listeners. Yeah. I've got some notes on Cryptosporidium, but maybe we can leave that later because I may
We
be
have to see
completely
if that's
wrong.
the right one,
Yeah, I might
Christina,
be
before you
wrong.
go down
Yeah.
that rabbit hole.
Yeah.
Vincent, you want to do next, and then we'll have Dixon finish it
Yeah.
off?
So when you were revealing this a couple of weeks ago, I thought this has got to be Giardia. But then a few people said if it's a pool, it's probably not, right? So I thought crypto would be great because it fits all the symptoms. But then, I mean, I'm really impressed by this email by Jay, which is, he focuses on your, first of all, the risky behavior that you mentioned, and also an unknown treatment, and could be, this probiotic yeast. And oh my gosh. So, but, he says it's either,
I think
what is it?
enterotoxic E. coli. I think that's what he
Yeah, he
said.
said E. coli, or there was another one here
Or a
now.
viral cause.
Oh, intratoxigenic E. coli, but that wouldn't be this program. Oh, wait, here. I suspect the parasite in the stool was not the cause of diarrhea. It's either Blastocystis hominis or Endolimax nana, right? So I'm going to stay with crypto, but I think he's onto something, or at least I suspect, because that risky behavior makes a lot of sense to me. So that's Cryptosporidium.
Was the treatment not prescribed after the stool diagnosis, though? I can't remember now.
Yeah, so that was a little thing. So the individual, the doctor with diarrhea, got a call, and then the medicine was prescribed in response to the parasite identified in the stool. So maybe that'll help Dixon.
I have nothing to add to this
Dixon
conversation.
needed
It's
no
very
help, right?
erudite, and it's right on the money. I want to address the diagnosis of Enterobius vermicularis a little bit. I would say that that's probably 3 standard deviations away from the mean in terms of
Oh, we think
causes of
we
agents.
think that person wrote in for the previous case, which did have.
Oh, no, I'm
pulmonary.
sorry. You're
So
absolutely right.
yeah.
You're absolutely right. You are absolutely right.
3 standard deviations, eh?
Well, he was still 3. So no, that's right. That's fine.
So are
No,
you
I
going
think when
with
you make a
Cryptosporidium,
differential
Dixon?
diagnosis for diarrheal diseases, you could write a book on it. In fact, there are books on it, which goes on and on and on. It's a sort of a verbal diarrhea about actual diarrhea. But you have to know a lot because it depends on where you are. It depends on how old you are. It depends on what your behaviors are. It depends on what your past history is. There's a whole bunch of stuff that goes into figuring out what the current episode of diarrhea is due to. And I like the guess about Vibrio, even though it's not a parasite. And she's absolutely right. It's not the Vibrio that does it, it's the toxin from the Vibrio that does it. Vulnificus is the one that's most common in the United States, and Hemolyticus is the second most common. Vibrio is not common in the United States, the one that actually causes cholera. But these others are picked up in raw fish bars and places where people congregate and enjoy an after swim meal of raw oysters and Bloody Marys, and then live to tell the tale sometime later on down the road. These gentlemen became infected, and it's even though the common um, perception is that you have to eat a lot of this organism, the Cryptosporidium organism, in order to catch it. Believe it or not, there was a clinical trial approved by IRB at some southern university in which graduate students participated in the infection. And they started out with a single oocyst, and then they went to 2, and then they went to 4, and then they went to 8, and then they went to 16, and then they went to 32, and you guess the next number was higher than that. They didn't have to go higher than that. 10 oocysts were the common denominator for initiating a standard infection with Cryptosporidium. It didn't result in a very long infection, of course, because none of these patients were immunosuppressed, nor did they have HIV/AIDS. So it was a risky clinical trial, though, I thought, because I'm not sure how they got that through an IRB. they would have probably rejected it in most other places. But thankfully, the experiment had been done, so I guess we're allowed to quote it, even though I know that all of those horrible experiments during the Second World War, conducted by the Nazi quotes unquote physicians on poor innocent people, cannot be quoted because they did not have any regard whatsoever for the rights of patients. They just wanted to see what would happen. So cryptosporidium is definitely my answer for this one.
Now, Dixon, you were trying to get a little more information out of me when I was presenting this.
I was.
And one, you wanted to know whether the physician identified as male or female, and you wanted to know if they were in a relationship with a same-sex partner. So I skirted those questions because I was worried we were giving a little too much of a directional hint. But what were you thinking about?
I'm not the one that I don't think I asked that question because I don't ask that question, but Vincent has a long history of wanting to know something about the sexual orientation of patients, and I don't remember asking you about that. I honestly don't. The patient denies. I'm sorry, I don't
Yeah.
remember it.
No, it
So,
was I used the word they, and you were you took it as
gotcha,
plural. But
gotcha.
so yeah, so this is an interesting case, and I think it highlights a few things. One is, as we saw, most of our listeners actually picked up I'm going to say on the right diagnosis before any expensive testing was done. Just they basically listened to the history. And, a lot of it is getting the right history. And that's really key. If you feed the right history, if you get the right history, the diagnosis sort of pops out at you, right? So, when you go through the history, basically we get this is a healthy, immunocompetent physician coming in with this watery diarrhea. There's no floating. It's not malodorous. Even before you get much, you start thinking about things like Cryptosporidium, like Cyclospora. And then you could even do a numbers game and say, well, you know what? We just don't see that much Cyclospora. So we're probably dealing with crypto and not cryptocurrency. And then we have a couple, I'll say, sort of epidemiological features here. And I tried to point them both out. So one is the physician lives in New York City. And what is special about the water in New York City? I'm going to let Dixon tell us.
Not filtered.
It's not filtered. It comes from these upstate aquifers.
Yep.
Right.
And so we sometimes have crypto in our drinking water in New York City. And it's sort of, I was thinking Dixon was going to start talking about Milwaukee if I didn't rein him in last time.
I could, but I'd rather have you talk about it.
Yeah, because Milwaukee was another situation where crypto was in the drinking water. And a number of individuals who did not have an immunocompetent immune system really got quite ill and sort of realized a lot of them were HIV positive, not just HIV positive, but actually had AIDS, had the immunosuppression that comes along with the advance of that disease. But the other was the risky behavior in my mind was swimming in a public pool. Oh my gosh. And so, and that's another epidemiological concern. Now, how do you sort it out? Did this physician, and I actually, are they a newcomer to New York City? Because the first time you get crypto, you get sick. The second or third time, you may have minimal symptomology. You're probably not going to end up in the ER because you will develop some sort of an immunity. So, a couple sort of interesting that I didn't add is, is this a physician that grew up in New York City? Is this a physician who came to New York City, which is the case for their training? And then how do you sort of parse this out? A lot of this is, so when were you in Florida? How long have you been back? If, the trip to Florida was 2 weeks ago, I start thinking about New York City drinking water. If I just got back 2 or 3 days ago, then I'm like, you may have picked this up in Florida swimming in that pool. And I think a lot of our emailers kind of parsed in. The issue is that similar to Cyclospora, this is a parasite that is not easily killed by chlorination unless it's actually done, dare I say, properly. That was the issue with the Cyclospora and the raspberries, right? They tried to, but it really takes quite a bit to actually get rid of these parasites. Now, I did like Jay's comment because not every parasite, not every eukaryotic organisms such as amoeba or tapeworms are actual pathogens. And there is a tendency, and we've talked about this before, where someone finds something, it's not going to be on the GI PCR, you're probably going to get results back this quickly, but on a stool ovum parasite, and then they just got to treat because it's there. So often it's not actually. But in this case, we approached it, or it was approached syndromically, which is, the way of the future, the way of the now, where someone comes in with a syndrome of diarrhea, you send off these multiplex PCR tests, and actually, the results come back. Some providers have this in the office. You actually can get results while the person is waiting in the office and immediately know this is the diagnosis. And in this case, it was a multiplex PCR, came back as Cryptosporidium. The hint that I shared was nitazoxanide is not necessarily a medicine that your general internal medicine trained physician or your hematology oncologist would have much familiarity with.
Right.
But they certainly, think about hematology oncology, a lot of immunocompromised patients, they certainly would know what TMP sulfa, what Bactrim would be. So,
Yeah.
But you said that you think he acquired it in New York City, right?
No, so the way you would know would be as if you delved in and say, well, how long have you been back from Florida? And I said shortly, just to try to help people know that it only been a couple days.
Okay,
but as I
got it.
explained, this doctor could have gotten that diarrhea just living in New York City drinking the tap water.
Does that happen?
Oh, yes.
Yeah, it has. I'd like to add something to that, Daniel, and you know that there is an ecological aspect to this as well. The upstate reservoir system of New York City's drinking water supply comes from 5 different reservoirs, and they drain the southern tier of the Catskill Mountains, which are not really full-fledged mountains, but everybody calls them mountains, so we will too. And the stools of the cattle and the calves that surround those 5 reservoir systems, whose rivers empty into them to keep them full. That's where the oocysts come from, and the oocysts last a long time. So that doesn't really explain though the seasonality of this. There's a biphasic aspect to this that they took a long time figuring it out, but when they did, they realized that most of the Cryptosporidium oocysts settle to the bottom of the reservoirs. And that occurs during the spring runoff. And then again, when the lake goes back to its winter mode. And I won't get into the details, but just know that the bottom of the lake, both in the spring and in the fall, is stirred up by the mixing of heavy cold water with the lighter warm water. So when that occurs, it puts all those oocysts in the water column. And then they're taken up, of course, by the pipes that are in the middle of these reservoirs. They're not near the bottom, they're right in the middle. To avoid this very situation, but that does not avoid it because in the spring and in the fall, you get a large input of oocysts into the New York City drinking water, and we can prove it simply by filtering the water in a 0.45 micron filter. You can actually see the algae in the water. When the algal blooms occur in the springtime, you can see a green deposit on the filters, proving that the water that we're drinking is enriched with lots of micronutrients, shall we say, and plant life, which I'm sure contributes in some healthy way to the way we develop. But every now and then, there are these pathogens that creep into our lives,
So
and
Dixon,
that's how that works. But
should we be filtering the water?
well,
Like here, I mean,
would
at the source, not at the
not
source,
at the
but
source. No, in your home, though, when
your
you
home,
drink
yeah.
the water that you drink, okay, is separate from the water that you wash your dishes in, or you flush your toilet, or you take a bath in. So yeah, we have one of these Brita filter
Right.
pitchers that you put the water through, and that removes almost every particulate you can think of, plus a couple of heavy metals as well. So yeah, filtering is a good idea for the water that you're going to drink.
Interesting.
You bet.
Yeah, filtering and using ozone, right, where they spray it up to the sunlight
Yeah,
can
well,
can
that's a little harder to come by.
yeah. But no, if you're living in New York City and you're immunocompromised, some people will actually put filters in their shower heads, right? Because
Oh,
you're
yeah, yeah,
showering
yeah,
and
yeah,
getting
yeah.
in
You're
your
right.
mouth.
You're right. You're right.
And some people will use filters for their
Wow.
water. So,
Yeah,
yeah.
Interesting.
indeed.
Here at the incubator, we have a filter. We filter the water because it
Yeah.
comes out of the tap. It's colored. It's like
Oh,
blue.
well, you have another problem where you
I
are.
think the piping in the
You have a
building is
100-year-old sewage system and
it's
a
getting some
freshwater
copper
drinking
into it.
system.
Yeah,
That's
but
right.
people periodically have bouts of unexplained diarrhea, right?
Yeah,
And
that's right.
maybe this is it. It's not severe, right? It's
That's right.
nothing that would send you to a physician's.
Unless you have HIV/AIDS and you don't
Yes,
know it
of
yet.
course.
Yeah. And on
Fascinating.
repeats, usually it's pretty minimal. You feel a little bit off and then you're fine again. So,
So,
yeah.
Daniel, the triple therapy for AIDS, if you're a newly diagnosed AIDS patient and you develop diarrhea from Cryptosporidium before you get treated with that triple therapy, will that save the life of that patient?
Yeah, so I guess I'll sort of terminology there. So, a person infected with HIV, right? They get infected with the virus. It may take a period of time before then a subset of HIV infected people will develop AIDS, right? So, CD4 counts below 200, an immune compromise where you get opportunistic infections. Back in the day when we would see cryptosporidium, we would actually initiate therapy, and the reconstitution of the immune system would help resolve what at that point could often be pretty protracted periods of diarrhea.
I have some niche
I want
information actually on Cryptosporidium if you're
yes,
interested.
I
Just
want
a
to
bit.
hear
Of
Christina.
course, of
In
course.
particular, Christina, this crypto that's in the reservoir. I want to know where that's coming from.
Oh, the Cryptosporidium in the Glasgow reservoir. Yeah, we did have an outbreak in 2000. I think they're not that uncommon. So, and I think in the year 2000 there was quite a big Cryptosporidium outbreak in Glasgow. That was caused, well, essentially it was cattle farming contamination that contaminated the water in Loch Katrine, which supplies Glasgow and the entire region with drinking water. And actually, that leads me very nicely to my niche interest, because I just wanted to mention there's kind of many Cryptosporidium species actually, but the ones that are most commonly associated with human infection are Cryptosporidium hominis, which is mostly anthropootic transmission, and then also Cryptosporidium parvum, which is a zoonotic species that also infects domestic animal, and is particularly problematic in cattle farms for young calves, so they can get really quite unwell. And it's particularly common in highly intensive production systems, and much less so in kind of low intensive farming systems. And so actually, from that point of view, actually, maybe high intensive farming is maybe quite problematic in the context of Cryptosporidium infection. And so if we look at outbreaks here in the UK, more than half of the outbreaks are actually attributed to the zoonotic species, Cryptosporidium parvum, and they can be linked to cattle farming, like, for example, the outbreak in the wider Glasgow region. And then the Cryptosporidium hominis infection, on the other hand, they're more often associated with kind of recreational water activities, well, swimming in the swimming pool, for example. And it's really quite interesting, actually. There's kind of, if you look at maps of where these species are more widely distributed, you can kind of see a correlation with the type of farming that is employed or what people do. So it's really quite interesting, but a bit nichey. But I thought I'd at least tickle your interest a little bit.
Oh, tickle, tickle. No, these are dairy cattle that mostly we were talking about in New York State, and I'm sure that's true also in the Glasgow area. And if they were to prevent the pregnant mother cow from being milked during the time that she's nursing her offspring, this would basically shut the infection down in the calf because the colostrum contains protective antibodies against infection. But they usually don't do that because they milk every cow every day, no matter what. And so that's the problem with commercializing animal husbandry. So there.
Right. Fascinating.
Yeah.
So Dick, what you're saying is the crypto in the upstate New York reservoirs is from runoff from cow farms,
That's
right?
correct. That is exactly right.
Not wild animals like raccoons or anything. No.
In fact, I knew someone. She was in our lab group while I was still practicing research, and she genotyped all of the Cryptosporidia that were sent to her from the patients in New York City, and some of them were from the cattle, but a lot of them were not. And then we started to look at the pet stores as to whether or not perhaps dogs or cats or some other mammal pet would be harboring this. But I think birds also could be a source for one of the species. What do you think, Christina? A bird could give us
Sorry,
one of these?
Sorry, I just kind of lost my concentration there for a second.
That's okay. I didn't mean to startle you.
That's okay.
I was recovering from your tickling. So birds can acquire Cryptosporidium too. Is that true?
I think there's Cryptosporidium for pretty much every species.
Yes.
I did actually delete that from my notes. So the CDC lists quite a lot of different animal species that can be affected with different Cryptosporidium
So the
species. But I
annual
think generally
migration.
they're maybe less relevant from a public health perspective. I'm not sure really.
I'm interested in waterfowl in this case because there is some seasonality to that as well.
Yeah.
And where do you suppose they land? They land in the nearest water supply. And in New York City, by the way, the central reservoir that supplies all the water from the 5 reservoirs to the 5 boroughs of New York. Isn't that interesting? You've got 5 boroughs, you've got 5 reservoirs, you've got 5 channels leading out of the reservoirs into a central pipe that puts all that water into the center part of New York City, and then it's redistributed back out into the 5 boroughs. And waterfowl actually land on that reservoir routinely. Geese, ducks, and other kinds of waterfowl as well. So they could easily contaminate water, even if we filtered the water that goes into that reservoir. It would not prevent every infection. That's the problem. That is,
I think a lot
home
of
filtration is your best bet.
Yeah, I think a lot of even New Yorkers don't really like when you hear like, oh, I went for a run around the reservoir in Central Park.
Yeah, exactly.
People don't think, you mean the reservoir? Like, is that where all the drinking water?
Yeah,
And this is really amazing, right? So
and it's quite
we got all
large.
this water. It's this huge reservoir, and I don't know. It's what is it like a mile around the reservoir? So it's a nice run. And, and so you can even getting, crypto into there because there are over 100 mammalian species that can actually get the different cryptos that infect humans and then secrete that stuff or excrete that stuff is actually probably the right word. Think about that. And then we end up, usually pretty innocuous at a low level. But if our immune system is not robust, then that New York City drinking water, which might be some of the best tasting water in the world, may not be safe.
That's why.
Ooh.
Yeah, you see, parasites they creep into your life by making the water taste good, so you'll drink more of it and you'll have more parasites. It's a conspiracy, but I believe that. I really, I won't even tell you where I heard it.
All right, let's give away a book.
Okay.
So we had 12 guesses, and I think maybe I put some people in who already won one, but you could let me know. We're going to make a random number between 1 and 12. Are you ready, Dixon?
I am ready. Here we go.
Number 4. Number 4 is Anthony, who wrote one sentence.
No, that's the best
that just
sentence.
Shows you gotta.
It was fantastic.
So here's what you do, Anthony. We have a new procedure to ease the shipping delays in these books. We would like you to send an email to TWiP at microbe.tv. Cancel that. That's the thing. Send an email to incubator at microbe.tv. Okay, incubator, because that goes to someone else who will ship them. Incubator at microbe.tv. Subject line, I won a book. You have to do that.
Ta-da.
Okay. Subject line, I want a book. Incubator at microbe.tv. And if you're outside of the US, we need a phone number for shipping. Okay. All right. So incubator at microbe.tv. Subject line, I won a book. That way we can pick them out from all the other many emails that we get.
Right.
Okay. Congratulations.
Indeed.
All right. Hero time, Christina.
Yeah, do we have time for the hero? I do have
Sure.
one.
Always.
Very good. So I would like to present Keith Vickerman as my parasitology hero for today. Keith Vickerman lived from 1933 to 2016. And so the information that I'm giving you today is from obituaries, but also from colleagues who have actually worked with Keith Vickerman here in Glasgow. So he was a parasitologist, and he made some really big contributions to our understanding of the biology of African trypanosomes, which cause sleeping sickness in people, but also he was also working on the trypanosomes that cause nagana in cattle. So let me tell a little bit more about him. So he was born in England, in the north of England, in 1933. And he was, as a child already, he was quite an avid collector of all things that he could find outside, like plants and animals and stones and bones. And I think a key moment that really shaped his future was a microscope that he was given by his parents for his 12th birthday. And he also had a really inspirational teacher at school that introduced him to the world of microbes through a book that was published in 1926, which described the work of some of the big microbiologists of the time, including Sir David Bruce, who described trypanosomes. So this kind of set him up on a path of becoming a scientist. So Keith Vickerman, he studied zoology at University College in London, and he graduated with a first-class degree in 1955. For his PhD, he moved to the west of England, to Exeter, and there he studied protozoan parasites of leather jackets, which are the larvae of crane flies. I'm not sure about the US, but I think here in the UK, we refer to crane flies as daddy long legs. And I think the larvae can be quite destructive to plants, and particularly grasses. And these protozoan parasites that he studied for his PhD were actually in the same order as the trypanosomes and leishmania. And so maybe from that point of view, it makes sense that trypanosomes would become the focus of his professional life. So after he did his PhD, he went back to London, and we already know he had an interest in microscopy, and actually in London he was able to work with an electron microscope, which was, quite a new thing at the time. I mean, not new, but they weren't just sitting around, those electron microscopes. But he was really lucky that he was able to use one, and he demonstrated some really important internal structures of trypanosomes, including that of the mitochondrium, which you will know are really quite interesting in trypanosomes. So he found that the mitochondrium of bloodstream trypanosomes differ significantly from the mitochondrium in the insect form trypanosomes, and that this was related to the availability of glucose in the respective hosts. So in the mammalian blood, there's a lot of glucose, and trypanosomes generate most of their ATP by aerobic glycolysis. But in the tsetse fly, there isn't really much glucose available. So the trypanosomes use mitochondrial oxidative phosphorylation to produce ATP. That's maybe a bit geeky biochemistry, but I think it's quite important. So he published that work in Nature in 1965. And actually in our show notes, I have copied a reference for this paper. Really quite an interesting read. He spent some time in Uganda, in the East African Research Organization in Tororo. and he characterized different isolates of Trypanosoma brucei from human and fly hosts. And he was collaborating with a researcher there, Matthew Cunningham, and they did some immunology work together, which at the time was agglutination and immune precipitation. And they used serum from rabbits that were immunized against different trypanosome isolates. And they were comparing variable surface antigens from humans and cattle or game. Some were common and others were unique. And this is relevant to Keith Vickerman's later major contributions to our understanding of trypanosomes. That's why I mentioned it here. So in 1963, he was awarded a Royal Society Tropical Research Fellowship, and this allowed him to continue his work on trypanosomes and work closer to the field. He spent some time in Nigeria, and this, but also his stay in Uganda, that allowed him to bring back material to the UK with which he was working. So in his earlier career, he contributed quite significantly to our understanding about how trypanosomes prepared for a host switch and how they survived this dramatic change in an environment by completely changing their metabolic activities. Okay, and then in 1968, Keith Vickerman, he moved from London to the University of Glasgow. And so this is maybe a hint why I have chosen him. And he continued to work on trypanosomes. And much of that work in Glasgow focused on finding explanations why trypanosomes can survive in the mammalian host. It had been previously described that trypanosome populations in human blood grew to high densities, then disappeared and re-emerged. And in a 1969 paper in the Journal of Cell Science, Keith Vickerman published work that revealed the dense surface coat of Trypanosoma brucei responsible for clone-specific relapse. And you absolutely have to have a look at that paper. The electron microscopy in there is absolutely astonishing. I've put a reference in the show notes and also a selected picture from that paper. Anyway, in 1974, Keith Vickerman then became the chair of the Department of Zoology at Glasgow, and he was appointed to be John Graham Kerr Professor of Zoology, and in 1984 he was a Regius Professor. And at a Regius Professor, I presume that's not something that you have in the US. That is a university professor who has or originally had royal patronage or appointment. So at the university, he taught many students. He had a very high teaching load, and I believe he was a very popular teacher. So I think I would have really enjoyed studying with him. So more kind of broadly, he also played a really important role in establishing parasitology and protozoology in Britain. So he was a founding member of the British Society for Parasitology, for example, and he got many rewards and prestigious honours, for example, a fellowship of the Royal Society in Edinburgh and the Fellowship of the Royal Society of London. And he also received the Royal Society Leeuwenhoek Medal and the Gold Medal of the Linnean Society. So he was well decorated, and he was a popular speaker at national and international conferences. And I read, although I have not obviously witnessed that he never repeated a lecture, which I think is quite a task if you have such a specialized area of research. So Keith Vickerman, he retired in 2000, which is the year after I arrived in Glasgow. And I never met him, but I have referred to his work in my MSc and PhD theses, and I continue to refer to his publications in my teaching. I know several researchers that worked with him, for example, Lawrence Tetley, who himself is a really gifted electron microscopist. And actually, Lawrence has been instrumental in providing excellent microscopy teaching to our DTMH students. And also many of my microscopy skills I learned from him. So, in a way, I've benefited from Keith Vickerman by proxy. And also I have access to a box of microscopy slides that Keith Vickerman prepared himself, which is a really valued treasure. So yeah, that's my hero.
Very good. Thank you. That's great.
You're welcome.
That is great.
All right, Dan, you got another case for us, or are you out?
I have a couple, so I was trying to figure out which one to present today. So I'm going to present one today, and then the next one that we do, I'm going to actually have a guest come and be involved in the unveiling. But this is, I recently asked about this case while I was off visiting Denmark. This last weekend, I headed over to Denmark and then went sailing in the Baltic with my son and cousin. We sailed down to Germany. It was kind of neat. Had a coffee and some afternoon sweets. Sailed back to Denmark.
Not very far, right?
It's just right there. So, but there was some novelty. But I then somebody reached out and wanted some input on this case. So the situation is a man in his 50s. He's been reporting months of abdominal discomfort. And then he goes and he's going to discuss the situation with a local pharmacist. He describes his discomfort, some nausea, some bloating of the abdomen. The pharmacist recommends that he take some mebendazole. Okay. He takes the mebendazole, and sometimes afterwards he vomits up a worm into the sink. So I actually get to see a video of this worm wriggling in the sink. The worm does not have any obvious segmentation, appears to be completely non-segmented. It's actually moving around. One end is very pointy and the other end a little less so. And it was sort of, what's going on here? And I thought I'd now open it up for some questions here from the crew that we can then include to help our listeners.
So Daniel, I presume you're not going to tell us how big it was.
It was roughly, I'm going to say about, 7 inches, something like that.
Oh, just imagine vomiting that up.
Looks
that
to
would
be about,
really ruin your day.
Look to be about that size on the video, but again, I'm sort of using the drain, as a reference there because there was no actual measuring.
Okay.
Wow. So give us some information on this person. Is he HIV negative?
So HIV negative, otherwise healthy.
Does he have a family?
Does have a family.
And everybody else is okay?
He was the only one that sought medical attention.
Has he been traveling lately?
So maybe the mebendazole is a bit of a hint. I thought that was helpful because that might impact, what we're thinking here. So mebendazole, it turns out, so I'm going to give you this, that this gentleman is actually, he lives in India, where the mebendazole is over the counter. Can be just given to you by the pharmacist upon recommendation.
So he wasn't actually in Denmark. Yep.
No. I was in Denmark when someone reached out to me, so just keep that. So,
that makes more sense with the mebendazole prescription by the pharmacist then.
Yeah. So do we feel good? Do we feel like we've given people what they?
Yeah, I'm good, but maybe the people out there need. So he lives in India, right?
Lives in India. He's got this abdominal discomfort, bloating, and he just vomited up a worm. And
does he live in
it's a pretty it's a big worm, right?
Does he live in a huge city or a small village?
It's in a city. Yeah, he's in a city.
Yeah.
Okay, that sounds good, Daniel. Thank you. Okay, so now if you want to guess, TWiP at microbe.tv, just put TWiP 233 in the subject line because sometimes we do the wrong emails. So now if you put TWiP 233 in the subject line, we'll know it's the right case. I'm sure not everyone will do that. But TWiP at microbe.tv. Okay, folks. And the show notes for this episode, if you want to read the case, because we'll put them there, excuse me, microbe.tv/TWiP. TWiP at microbe.tv goes your guesses, or if you want to say anything else to us, that's fine. Just be nice. And if you like what we do here and all of our other science programs, we'd love your support. Go to microbe.tv/contribute. Daniel Griffin's at Columbia University Irving Medical Center. Parasites Without Border. TWiP.com. Thank you, Daniel.
Oh, thank you. And everyone be safe.
Dixon Despommier is at trichinella.org, thelivingriver.org. Thank you, Dixon.
Thank you, Vincent, and everybody else on the show. It's always a wonderful time to share our knowledge with the public.
Christina Nowlis at the University of Glasgow. Thank you, Christina.
Well, thank you for a lovely evening.
The lovely evening. That's right. Even here, it's an evening. It's 6:38 p.m. And what time is it there? 11:38?
Yeah, 11:38.
I'm Vincent Racaniello. You can find me at microbe.tv. Music on TWiP is composed and performed by Ronald Jenkins. And I'd like to thank the American Society for Microbiology for their support of TWiP. Okay, we have to agree ahead of time who's going to say this, because last time Dixon and I clashed.
I'm doing it. I'm jumping in.
So good. You just do that.
You've been listening to This Week in Parasitism. Thanks for joining us. We'll be back in 2 weeks.
Another TWiP is parasitic.